Hello friends, let us learn a new topic today which is atrophic rhinitis. So this is one of the important topic in ENT. So first we will learn about the etiology of atrophic rhinitis. So etiology is here hereditary. It can be due to hereditary or endocrine pathology is seen. Endocrinologically, estrogen deficiency is most common when compared to others. Then race. If you see race, whites and yellow races, there is more common atrophic rhinitis incidence when compared to others. Then nutritional deficiency, especially deficiency of vitamin A, D, E is common. Iron deficiency is also common. Then it can be due to infections like Klebsiella ozonae, diphtheroids, Coccobacillus osceola. So all these are the main causes. Then it can also be associated with autoimmune processes like destruction of nasal, neurovascular and glandular elements. So these are the etiological features. Now coming to the pathology. Due to these etiological features, all these etiological features leads to the loss of ciliated columnar epithelium is lost, and this ciliated columnar epithelium is replaced by stratified squamous epithelium, and along with that there is atrophy of seromucinous glands, and the turbinates resorption also occurs along with widening of nasal chambers. Because of turbinate resorption, the nasal chambers get widened. There is also loss of sensory nerve. Then there is excessive crusting. This loss of sensory nerve leads to excessive crusting. Because of crusting, this will obstruct the nasal cavity and forms nasal obstruction. Actually, when compared to widening, this nasal obstruction is more. So as a result, there is abnormal nasal patency is present, but that is less than nasal obstruction. Then if you see clinical features, it is common in low socioeconomic status. It is more common in females at puberty, anosmic, and there is foul smelling. Smell comes from the patient. Actually, because of loss of epithelium, there is secondary bacterial infection which will lead to foul smelling discharge. And this discharge actually comes from her, but she cannot feel the discharge. So that is called as merciful anosmia. Why can't the patient feel the smell? This is because of the loss of the sensory nerves, which I have already told you. Because of that, she can't feel the smell. Then there can be nasal obstruction and sometimes epistaxis. So now coming to the signs most commonly roomy nasal cavity will occur, and there is greenish large crusts are associated with it and shriveled turbinates. Then if you try to remove the crust, then bleeding can occur, which is important. Bleeding can occur. Sometimes if you see nasal mucosa appears pale. Why does it appear pale? Because of the atrophy of feeding arteries. All the feeding arteries gets atrophied, and because of that the nasal mucosa appears pale. Then there is obliterative endarteritis also, and septal perforation occurs sometimes. Then coming to the atrophic changes. There are some atrophic changes, especially you will see them in nasal mucosa. Atrophic changes can occur, and they can even occur in the pharyngeal mucosa and larynx also. There can be eustachian tube obstruction can occur, leading to hearing loss. If you see the investigations, most commonly X-ray paranasal sinuses can cause Waters view, which leads to thickening of the wall of sinuses. Now, treatment, if you see treatment, it can be medical treatment or there can be surgical treatment. So in the medical treatment, you will have to give warm alkaline solution, nasal solution. You should give nasal alkaline solution which contains 28 ml of water. To this you will add 1 part of sodium bicarbonate with 28.4 grams. You will also add sodium biborate, which is 28.4 grams again, and you will add 2 parts of NaCl, which is 59.7 grams. Then you will loosen and remove the crusts. Then you can add, then it will loosen and remove the crusts. Then glucose, 25% glucose in glycerin is also painted, and once you paint 25% glucose in glycerin, this will convert glucose to lactic acid, and this lactic acid will inhibit proteolytic organisms. Then this glycerin is hygroscopic. So both these, glucose being inhibiting the proteolytic organisms by converting into lactic acid, and glycerin being hygroscopic. So both these will help in loosening the crusts. Then we can also give local antibiotics because there is infectious etiology associated with it, especially with Klebsiella ozonae and diphtheroids and Coccobacillus azeola. So because of that we give antibiotics, which is chemicitin antiozina can be given. Chemicitin antiozina solution, which contains chloramphenicol 90 milligrams, and we can also give estradiol dipropionate, which is 0.64 milligrams, vitamin D2 900 international units, or propylene glycol can also be given. Then if you do, then you can also give potassium iodide. This potassium iodide increases the nasal secretions, and human placental extract can be given, and it is given in the form of submucosal injections. This will increase the blood supply to nasal mucosa. So this placental extract is also important. Then we have rifampicin, streptomycin, and estradiol sprays. Estradiol spray can also be given. Streptomycin and rifampicin will decrease the crusts and thus decrease the odor, whereas estradiol spray decreases vascularity. Now coming to surgery, the main aim of the surgery is to decrease the size of roomy nasal cavities. We have two types of operations, one being Young's operation, second being modified Young's operation. In Young's operation, you will have closure of both the nostrils. You should do and open that after 6 months. You should close both the nostrils, and then you should open that nostrils after 6 months. Then in modified Young's operation, you will have to do partial closure of nostrils with 3 millimeter hole for almost 2 years. So you are closing it one part of the nostril, that is Young's, whereas if you close both the nostrils, then that is Young's. Only one nostril, then that is modified Young's operation. So this is about atrophic rhinitis. There is one more operation which is named operation, which is done surgery, which is a Lorentz-Locker operation. So here you will have to narrow the nasal cavity by submucosal injection of Teflon plate and by insertion of flat cartilage and bone and also Teflon. Then there are strips under mucoperiosteum of floor and lateral wall of the nose. Then we have next about rhinitis sicca. The next topic which we have to learn here is about rhinitis sicca. So in the rhinitis sicca, here the patient works in hot, dry, dusty surroundings. Most commonly it is ironsmiths, bakery workers. This rhinitis sicca is common in them because of increased heat. The respiratory ciliated columnar epithelium, which is present in the anterior part of the nose, that gets replaced by squamous epithelium, along with atrophy of seromucinous glands. This occurs mainly because of the heat from iron, iron welding for ironsmiths, and heat from oven for bakery workers. Because of that hot, dry, dusty environment, the epithelium gets metaplasia and atrophy of seromucinous glands occurs. So treatment is, first you will have to correct the operational surroundings, then you should give antibiotics, and steroid ointments can be given, and then you should do nasal douching. So this is about the rhinitis sicca. Then we have one more which is called as allergic rhinitis. So this allergic rhinitis is mainly type 1 hypersensitivity reaction. In this type 1 hypersensitivity reaction, you have allergens. There are two types of allergens, one being seasonal allergen, second perennial allergen. In seasonal allergen, mainly particular season is involved. In perennial allergen, this is present throughout the year. In seasonal allergen, there is glass, flower, pollen are involved. It is most commonly seen in morning, especially when symptoms get worse, and it is increased by dry, windy conditions. Whereas in perennial allergens, these are present throughout the year, and there are sprays. These include sprays, dust, smoke, and perfumes. Symptoms are not severe. Okay, so these are seasonal allergens, and we have perennial allergens. Then if you see the next clinical features of this is, it is 12 to 16 years age group, it is more common, and it peaks in third to or fourth decade. Itching of eyes or nose and sneezing is common. Then we have profuse watery discharge with post-nasal drip is also common. There is concomitant coughing and wheezing. Nasal obstruction can also occur. So all these are the features of allergic rhinitis. This is because mainly of type 1 hypersensitivity reaction, where there is increased IgE and mast cell recruitment causing this allergic rhinitis. Now the symptoms are, signs are, nasally you see the nasal mucosa being pale, hypertrophied and bluish. Then there is transverse crease which is present on the nose. This transverse crease is due to upward rubbing of nose, where you see allergic salute. Then if you see in the eye, there is this is allergic salute which you see. Then in the eye you will mainly see blocking of eustachian tubes. Then you will with this blocking of eustachian tube leads to otitis media with effusion. Then if you see pharynx, this pharynx causes glandular pharyngitis, and it can also involve larynx causing edema of vocal cords and hoarseness of voice, and it also causes hoarseness of voice. In the eyes there can be dark circles, allergic shiners. It can cause dark circles, allergic shiners, lower eyelids, especially skin causes present skin creases. These skin creases are Dennis Morgan lines. Then if you see the treatment, before treatment, investigations you should do blood tests because it is a type 1 hypersensitivity reaction. You see eosinophilia, increased total leukocyte count is seen, and differential leukocyte count is also increased. Then there is nasal smear. In the nasal smear you see eosinophils. Then if you do skin test is of many types. It can be prick test or scratch test, or intradermal test can also be seen. Then we have radioallergosorbent test, where there is serum IgE measurement we do with this radioallergosorbent test. We do serum IgE measurement because serum IgE is the part of type 1 hypersensitivity reaction. Now coming to the treatment. Treatment is, you will first have to avoid the allergens and you will give antihistamines. These antihistamines are mainly the first line of treatment for allergic rhinitis. Many are available without prescription also, these antihistaminics, so these are tried first. Then in the late phase of reaction we can give corticosteroids. These corticosteroids will mainly prevent the influx of inflammatory cells, causing immunotherapy. This will prevent the influx of inflammatory cells. Thus it is a immunotherapy can also be given. Then if you see decongestants, these decongestants will activate adrenergic receptors and these will cause vasoconstriction of nose and thus decrease the turbinate hypertrophy and congestion, and thus these will improve the nasal patency. So the most commonly used nasal decongestant is oxymetazoline, which can be given intranasally. Then immunotherapy is also available. So this is about the allergic rhinitis. Next, what are the contraindications of immunotherapy? We are talking about immunotherapy. The contraindications are whenever there is coexisting asthma, patient with beta blockers, other medical immunological diseases, then age less than 5 years, and in pregnancy these are contraindicated. Then we have the next topic, which is vasomotor rhinitis. In vasomotor rhinitis or non-allergic rhinitis, it mainly occurs due to parasympathetic overactivity which occurs, and this parasympathetic overactivity causes congestion and vasodilatation. So if you see symptoms, it is mostly emotionally unstable. It occurs in emotionally unstable patients. In females, more commonly seen when compared to males, common in 20 to 40 years. There is paroxysmal sneezing, which occurs just after getting out of bed. Then it causes nasal obstruction. Then there is excessive clear rhinorrhea occurs. There can be post-nasal drip also. So if you see signs, nasal mucosa is most commonly normal. Then there is hypertrophied turbinates are seen. And if you see the treatment, in the treatment you should give medical therapy and you can also give surgical therapy. In the medical therapy, you will have to avoid the provocating factors. You can give oral or nasal decongestants like phenylephrine, nasal xylometazoline can be given, and you can also give topical and nasal steroids. So if you see surgery is mainly to treat the complications. In the surgery, you can give VDN neurectomy. This VDN neurectomy helps in sectioning of parasympathetic fibers, that is cutting the parasympathetic fibers. The next topic is about rhinitis caseosa or nasal polystetoma. Here there is mainly accumulation of cheesy material or white offensive debris occurs, and there is invasion occurs. Why does this cheesy material accumulates, and this also invades the bony structures and soft tissues of face. This is usually unilateral and it is most commonly seen in males. Here you see removal of debris and repeated irritation will occur. So the treatment is removal of debris and repeated irritation. The next topic is rhinitis medicamentosa. In this you see excessive use of topical decongestants are seen. Decongestant nasal drops are common, and then these nasal decongestants, for this patient the nasal decongestants should not be given more than 5 days. Not only this patient, for any patient you should not give topical decongestants, nasal decongestants more than 5 days. If you give them more than 5 days, there is increased chances of this rhinitis medicamentosa. How are you going to treat this? Treatment of this disease is withdrawal of offending drug should be done, and you should give short course of systemic steroids, and local steroids are important. So this is about all the rhinitis. So thank you guys for watching my lecture. Thank you.